My name is Tia Teriak. Welcome to What's Up, Doc, a monthly lecture program presented to you by the Concord Hospital Trust. We would like to recognize and thank the Walker Lecture Series for their generous sponsorship of What's Up, Doc. The Walker Lecture Series was established here in Concord in 1892 from the bequest in the will of Abigail Walker. Per the terms of her will, the Walker Series offers lectures on history, literature, art, and science, as well as dramatic, musical, and literary performances. All events are free to the public and are held at the Concord City Auditorium. We encourage you to check out their website at walkerlecture.org to view their calendar of programs. We've got a wonderful program for you today. I've spent all week trying to pronounce Dr. Marietta's specialty. We'll see how I do. Today, What's Up, Doc welcomes Dr. Chandler Marietta from Concord Hospital, Otolaryngology, Laconia. Dr. Marietta attended the University of Rochester School of Medicine, where he received the degree of medicine with distinction in research. And he went on to complete residencies at Strong Memorial Hospital, also located in Rochester. Dr. Marietta is board certified in otolaryngology. He is originally from Michigan. However, Dr. Marietta lives now in New Hampshire, where he has served the Lakes region and Plymouth area for the past 10 years. Dr. Marietta's professional interests actually extend globally, and they include medical research, education, and building sustainable relationships with local physicians in developing countries, such as Zambia, which is in southern Africa. I'm sure that could be a whole presentation on its own. On the personal side, Dr. Marietta enjoys spending time with his family and his dog, and he travels and he enjoys running, skiing, snowboarding, tennis, kayaking, paddleboarding, oh my goodness, films and music. Please join me in welcoming Dr. Marietta.
Thank you everybody. The presentation is Otolaryng what? Services provided by the most mispronounced specialty now and beyond. There are some specialties that would probably challenge me on the most mispronounced, but I think it's probably pretty close. So most of you are actually probably in a better situation than I was in even up till my second year of medical school, in that you know that ear, nose, and throat is actually a specialty. But many of you are probably similar to this guy right here, which is my dad, who after even 18 years in the specialty still can't pronounce what my specialty is. So let's first things first, how to pronounce it. So oto, which is the root for ear, we'll go through that in a little bit, is pronounced o-toe, like, oh, I stubbed my toe. Okay, so o-toe. Next is lair, L-A-I-R, like Larry Bird. Y-N is in, like LinkedIn, if you happen to be involved in kind of computers and internet, and then gology. So putting it all together, otolaryngology. Okay, so it is getting a little warm in here. Just wear a t-shirt from now on. So moving on, I mentioned in the first slide, and as probably most of you know, the specialty is actually ear, nose, and throat. And at one point, it was eyes, ears, nose, and throat, which would be ophtho-oto-rhino-laryngology. So even though laryngology is fairly cumbersome, it's actually an improvement. And let's break it down. So oto, like I mentioned, is ear. Laryn or larynx is the throat. And again, ear, oto, nose, rhino, throat, larynx, otorhinolaryngology. And again, thankfully, we've just shortened it to otolaryngology. So we oftentimes, because it's such a difficult specialty to pronounce, we shorten it to ear, nose, and throat. Okay? Now there's some problems with that, the first of which being we frequently say ENT. Now ENT, if you say it very quickly, often sounds like EMT, and again, it is not EMT or emergency medical technician. I've had many conversations with people when they ask me, oh, what do you do? I say, oh, ENT or some variation of that, and they often kind of go into, oh yeah, when I, had my heart attack, the EMT came and entered it. And so they start telling me all about that, and again, very skilled, I'm very appreciative for their services, but very different skill set. So what are we then? So what is ear, nose, and throat? Well, first and foremost, we're surgeons, which I think some people find surprising. But I have the emotional and psychological scars from residency to attest to that. So if our residency is 5 years long, and then if we do additional training, it's of course more than that. And if you guys are familiar with Grey's Anatomy or ER or any of the other medical shows where they show surgeons, it can be a little brutal. So definitely we are surgeons and have the knowledge and I guess it's a slight pride of being surgeons, but that's first and foremost what we are. We are a surgical subspecialty. So where do we operate? Well, of course, the ear, nose, and throat, right? But it's not quite that straightforward, actually. You can get some sense of that by what our academy's name is. So our academy, our national organization that represents us, is the American Academy of Otolaryngology, Head and Neck Surgery. So not the American Academy of Otolaryngology, American Academy of Otolaryngology, Head and Neck Surgery. So the way that I kind of frequently describe it to people is it's all surgery and procedures in the head and neck region, except brain and the spine. Of course, that's neurosurgery. Eyes, which we once were a part, but thankfully has sectioned off because ear, nose, and throat is a big enough specialty in and of itself. So thankfully, eyes fractured off and is the specialty ophthalmology. And teeth, which is oral surgery or dentistry. So all surgery procedures in the head and neck region except brain, spine, ears, or eyes, ears. I'm laughing for reasons that will become obvious in a second. Eyes and teeth. So does that include the facial bones? Yep. So if you have a facial fracture, we're one of the specialties that helps you with that if a procedure or surgery is needed. What about the oral cavity? So again, not ear, nose, and throat per se. That's the lips, the tongue, the cheeks, the palate, the uvula, the little punching bag that hangs off the back. Yep, that's our specialty as well. What about the tonsils? Probably one of the, if not the most common procedure that we perform. So indeed, tonsils are a big part of what most ENTs do. What about the sinuses? Well, sinuses, not quite the nose, but kind of part of the nose. Of course, we do the sinuses as well. What about the neck? So not ear, nose, and throat on the inside. What about the neck on the outside, or kind of on the outside? The salivary glands, the parotid glands, which are little glands that are on the sides of your cheek, the thyroid gland, the lymph nodes. Yep, yep, and yep. Okay. What about the skin? We got facial bones, we got oral cavity, we got tonsils, we got sinuses, we got the neck. What about the skin? Again, does that kind of fall within all surgery procedures in the head and neck region? And yep, and this is one thing that I think most people, some people can figure out, oh, okay, well, ear, nose, and throat, probably the tonsils, probably the sinuses. But actually, a quarter of my training is in facial plastic surgery. So if somebody comes to the emergency department after a dog bite, after a fall, and they have a big cut on their face, I'm one of the doctors, including my colleagues, that will come help kind of fix that and try to put it back together and minimize the scarring. So in that, really, there's a couple of aspects of that. There's the cosmetic aspect of that, which is kind of in the repair, but also there's the whole world of cosmetic facial surgery that indeed I have some training in, but most of ear, nose, and throat doctors don't do. That usually is a facial plastic surgeon that has additional training, and they just focus on that. They just focus on facelifts and blepharoplasty or surgery related to the eyelids and such. Rhinoplasty or surgery on the nose kind of falls in between, because you can have functional rhinoplasty, which is to improve the breathing, and oh, while you're there, doc, can you do this or touch up that or make it look like that? So sometimes we do indeed do that. But the other aspect of rhinoplasty is to make it work better, or a functional rhinoplasty. Probably the most common thing that me and my colleagues do is skin cancer removal, excision and reconstruction. And this is again for skin cancer. It can also be for precancerous lesions, or actinic keratosis is probably the most common one. Those are those red, crusty lesions on the face that can become cancer. And then benign lesions that are symptomatic. So if it's a benign lesion and you want to remove it because you don't like the way that it looks, that's cosmetic. But if it's causing symptoms, if it's bleeding, if it's causing soreness, then that's often something that we remove. And these are just kind of 3 examples of this. So this is a skin cancer that was removed from the cheek. So a fairly big defect, but thankfully people's skin can move around. And this was after a repair. This, again, kind of a big lip cancer that was excised. Again, fairly big defect. You look at this and go, oh my gosh, how do you put that back together? But actually moving the skin around and making sure the edges are lined up can lead to a pretty good result. This is one of the surgeries that I do. I don't think anybody else in my practice does this, just because I have, I think, a little bit more experience with facial plastic surgery, which is a forehead flap, and it's used for nasal reconstruction. So again, fairly big defect, and interestingly, the way to repair this when it's this big is actually to take skin from the forehead that is attached to the blood vessel in the forehead, keep the blood vessel attached, and rotate that skin onto the face. Quite dramatic for to see it for the first time, and certainly for people to go through with it. But then you go back 3 weeks later, typically, and what's called divide and inset, kind of remove the intervening portion. So this is kind of what it looks like, kind of when it's in place. Remove the intervening portion, and it can have a really quite amazing response and reconstruction. So adding all this together, this is really otolaryng, orosino, cervicocephalo, salivary thyro, lymphodermogology. So I guess we should be thankful, even though otolaryngology is difficult to pronounce, that we still keep it as otolaryngology. I've just kind of learned through the years, and I don't know what Dr. Emily, kind of how he evolved, but I basically just say an ear, nose, and throat surgeon. And when people ask me kind of what I do, I feel like that's probably the easiest, and but again, isn't complete, but it is what it is. So in addition to just kind of what most otolaryngologists do, we also have fellowship training, which is additional training. So if 5 years wasn't enough as a surgical residency for some of us, we want actually more training. And those are really kind of in those anatomic areas. Because each area, believe it or not, each area to operate in that area requires a whole different instrumentation and a whole different skill set. So operating in the ear is completely different than operating on the skin, is completely different than operating on the sinuses, is completely different than operating in the throat. And so some surgical subspecialties or some surgical specialties pretty much use the same instrumentation. But with ear, nose, and throat, that is not the case. And so because of that, when the complicated things arise in our area, then we send them to these folks. And that includes ear, which is otology, nose and sinuses, which is rhinology, throat, laryngology. Kids, again, complicated things. All ear, nose, and throat doctors, or I would say almost all ear, nose, and throat doctors treat kids. But if it's a very complicated issue, then we send them to pediatric otolaryngologists. Cancer, which, if you weren't confused already, we refer to as head and neck, and head and neck cancer, but we shorten it to head and neck, or cosmetic facial plastics, like I mentioned. So again, tend to be for complicated and extensive issues. Myself, I have additional fellowship training in ear or otology, and this is me doing, don't worry, the patient was being taken care of, and this was just an extra staff member that popped in to help me out, taking a picture. This is me doing kind of a minimally invasive ear surgery with a telescope kind of through the ear canal. So to make things even more complicated, as you probably have kind of discerned as the presentation has gone on, but Dr. Marietta, this seems like there's kind of, doesn't dermatology do some of that? Wait a minute, I went to my general surgeon for my thyroid issue, and doesn't plastic surgery get called to the emergency room, or don't they do some of this? Doesn't oral surgery kind of deal with facial bones? Doesn't vascular surgery deal with the blood vessels in the neck? And my answer to that is yes. So again, not overly straightforward, but all surgery and procedures in the head and neck region except spine, brain, teeth, and eyes. There's also medical, or we also treat medical issues. So if there's infection, so it's not just surgery, although typically the majority is, but we also treat medical issues such as infections, allergies. We even have a academy, American Academy of Otolaryngologic Allergy, or AAOA, as we refer to them as. Some of us treat asthma, and then you have inflammatory conditions of the throat. So there absolutely is additional overlap with your primary care doctor, an allergist or immunologist, which is a doctor that comes up through the internal medicine kind of training, and then gastroenterology, which again kind of comes up through the internal medicine training. So ear, nose, and throat, yes, but no. Otolaryngology, yes, but no. There's surgical overlap, there's medical overlap. So again, coming back, all surgeries, procedures in the head and neck region, except brain and spine, ear, eyes, and teeth. That's the best I can do for you to sum up kind of what we provide. And then why not just a head and neck surgeon then? Doc, I mean, yeah, okay, we know about neurosurgeons, we know about dentists and oral surgeons, we know about ophthalmologists. Why not just call yourself a head and neck surgeon? And I think there's a resistance to that, again, for what I mentioned before, because we, as otolaryngologists, refer to head and neck surgeons as head and neck cancer surgeons. So we would call them head and neck. So I think, again, it'll probably be otolaryngology or ear, nose, and throat to stay. Thankfully, we are not veterinarians as well. There's enough that we have to deal with. So I really can't do a presentation where where I'm disseminating any information and have the stage without sharing some pearls from our practice. So I don't have a lot of these, but there are a couple. And these are conversations that I have every single day with patients. So the first is Q-tips are bad, okay? Even and as an ear surgeon, I even feel this perhaps more strongly than my fellow otolaryngologists. Q-tips are bad. Why are they bad? And it really comes down to anatomy. So, and I like this picture for a number of reasons, even though it's just kind of a cartoon, in that if you look at the size of the Q-tip and the size of the ear canal, they are almost the same. So when we place a Q-tip in the ear canal, it is almost filling the ear. And if there is wax in there, we always get a little bit out and we always feel very satisfied about that. Oh, I got a little wax out. But as somebody who's dealt with these issues every single day, you tend to push more in than you get out on the Q-tip. And if we keep pushing more and more in, then obviously that will eventually lead to kind of, at best, hearing loss, which is, and I say that at best, and obviously hearing loss is very frustrating to deal with. At worst, an infection, because it can trap moisture, and that moisture can get infected. And then, even worse than that, so I shouldn't say at worst, or worse than hearing loss, infection, and even at worst, I've seen where the wax will trap the skin that's being that skin does what skin does, which is it multiplies, divides, and sheds, and it will shed out of it will want to shed out of the ear canal, but it can't go anywhere because that wax is there, and so it will collect it. And skin has a very interesting property that when it sits, it will actually start to erode structures. So I've taken care of patients and still take care of patients on at least a weekly basis where they had a wax issue that led to skin collection, which led to erosion of their ear canal, and then that can have all kinds of issues. Sometimes that actually leads to surgery. So thankfully, most people can get away with using Q-tips, but please don't try. Oftentimes people will come in and they'll say, no, I don't use Q-tips. And then I look in their ear and they have this nice ball of wax with this wonderful spherical indentation. And so, the findings are the findings. So now, wax, we kind of have a perception that wax is a bad thing. And that's why we want to get it out. But actually, wax is a very positive thing. It's nature's way to really clean the ear canal. We have this hole in the side of our head, and so we need a way to get debris out of there. And so we have wax. And wax is made in the middle portion of the ear canal, and the skin migrates from the eardrum out. And so wax is made here, the skin migrates out, so the skin kind of carries the wax with it. And so when it gets to the outside, just wipe it away. But if it's in the ear canal, it's a good thing. And it's sticky because we have debris that gets in there, and so we want that debris to stick to the wax. It's also very acidic, and that acidic nature of it prevents infection. So generally, we don't want to take the wax out as long as it's not causing problems. Now, of course, it causes problems sometimes, and especially when we use hearing aids and are putting hearing aids in our ears, and so we're kind of pushing the wax back in. So if that's the case, then the best thing to do is actually to come and see us, and we kind of remove it. And again, we're surgeons, so we have all this instrumentation, we have a microscope, we can kind of remove it as safely as possible. Most people have had their ears irrigated at some point. As an ear specialist, I understand that I can't see every last person with wax in their ear, and so the primary care doctors, that's mainly their kind of what tools they have. Most of the time, you can get away with that. But I'll tell you, as somebody who, when I was in my late teens, and I had a wax impaction and had irrigation, it caused a perforation in my eardrum, it caused a ton of pain, I started spinning, and I also, again, as an ear specialist, if that water causes swimmer's ear, so that's what swimmer's ear is water in the ear canal that leads to an infection, I'm typically the guy that they send you to take care of that. So again, I would prefer that people not do irrigation because of the problems that it can cause, but I of course kind of understand that I can't take care of everything, and nor can my colleagues take care of all the wax in the world. So as long as we kind of understand it generally can stay there, and so it doesn't have to be removed, and it actually has a positive quality to our adds positive things to our lives, then I think that in and of itself, if you walk away with that, I'll be a happy doctor. The next thing is sudden hearing loss. So some people are pretty nonchalant about their health, and so in the hearing gets down or whatever, and we have aches and pains, and okay, well, I'll kind of check that. Sudden hearing loss is a little different situation. So if you or loved one or anybody you know loses their hearing all of a sudden, then we consider that to be a semi-emergency. It's not a rush to the emergency room in the middle of the night type of emergency, but it's call the primary care doctor the first thing the next day and try to get in to see us type of scenario. And particularly if you kind of scratch your scalp behind the ear and you can't hear that scratch. So that's just a little kind of trick. If you can hear that scratch, then you can take a deep breath, and it's probably not going to it's probably something unrelated. But that's something that we consider something we need to deal with sooner rather than later. Now, with this being said, most cases of sudden hearing loss are actually not an emergency. They're usually due to wax or usually due to fluid in the middle ear space. And that can resolve itself or can be taken out. But if it is due to the inner ear, then that is something that we want to institute treatment sooner rather than later, because we know that the sooner we treat that, the better the outcomes. Ideally, within the first 72 hours, up to 6 weeks. But if we can get some treatment in the first 72 hours, that's the best thing. Okay. The next thing is...
What causes the sudden ear deafness or whatever it is way in?
Yeah. So it's usually some insult to the inner ear. And that's a very diplomatic and general way to say it. And the reason I actually convey it as such is because it can be a number of different things. And from anything from a tumor to a virus getting into the inner ear and causing inflammation, to the blood vessels being compromised, causing the blood flow to be not go to the inner ear the way that it should, and that can cause damage, to inflammation from other things. So that's, and then in some cases it's idiopathic, or the fancy medical way of saying we don't know. In most situations that it's idiopathic, we think that it's probably viral related in some way, shape, or form. Okay. Yeah, sure. So the next thing is, at some point, most people, maybe not most, maybe this is a specialty bias. It seems like everybody uses a nasal spray that comes into my office, but many people use nasal sprays for one reason or another. Saline sprays, and then we have, of course, the nasal steroid sprays for allergies and such. So this is a little anatomy lesson. And you all will kind of leave here with far and away above most people with regard to understanding about this. So when we put a nasal spray in, we need to keep in mind that that our inclination that our nose is in the middle is actually not the case on the inside. So on the inside of the nose, the thing that's in the middle is actually the septum, the nasal septum, which separates the right and the left nasal cavities. So if we put in a spray and point up and in, because that's our conception of kind of where our nose is, and everybody does this. Okay, I did this before I was an ear, nose, and throat doctor. So everybody does this. Is just kind of how we kind of think of our nose. If we do that, we spray the septum. And if we spray the septum, first of all, the spray is not going to work. It's not going to get to where it's going to where it needs to. And secondly, if we spray the septum over and over again, particularly with a spray that has medicine in it, like a nasal steroid spray, it will get drier and drier and drier, and then eventually it can bleed. And so that's actually a pretty common cause of nosebleeds, is people using nasal sprays. So how do you put the nasal spray in then? So the septum in the middle, in the inside the nasal cavity and the openings of the sinuses. This is the forehead sinus and cheek sinus. We also have sinuses between our eyes and sinuses in the middle of our head called the sphenoid sinuses, but basically they all drain in this area. And so that's where we want the spray to go. So I often tell patients, and I'll get at least a pen, because it gives you some sense of a nozzle, is hold it with the opposite hand. And so if you're putting your left side, hold it with the right hand and point it out, up, and slightly back. So out, up, and then slightly back. And if you point it toward the inner corner of your eye, of course within your nose, within the nose, I stress that for obvious reasons. I have had a patient who came back and with eye complaints. So within the nose, then that's about where you want the spray to go. Okay. Again, just a little pearl. So these are all the services that we provide. These are all the services that are available here at Concord Hospital and in the Lakes region and Plymouth and Wolfboro and North Conway. We have, my colleagues and I go kind of all over this area. What's coming up? So what's coming up is the Hearing and Balance Center. So we take care of a lot of hearing issues. We are one of the doctors that take care of balance issues, but we are not the only one. And so because of that, and this will be clear in kind of the next slide, because of that, we really wanted to kind of centralize it and make it easier for patients to access these types of services. And so we're in the midst of establishing a Hearing and Balance Center here. I'm still Heather and I are still kind of conversing about what we're going to call it, because we want to call it something kind of, catchy, but it might just end up being the Hearing and Balance Center. But in any case, that's essentially what it's going to be, and it really has these components. I know this is a very busy slide, but I'll kind of break it down to you. So this is kind of me and my colleagues. So the surgical medical side of it, we're hopefully going to start doing cochlear implants here. We have Baha is a bone integrated implant for very specific types of hearing loss. We have chronic ear issues. You saw the picture of me doing endoscopic, kind of minimally invasive surgery. Stapedectomy is another type of surgery. Tympanic membrane and ossicular chain reconstruction is the eardrum and the hearing bone reconstruction. The eustachian tube dilation, kind of trying to help it to work a little bit, as well as medical management. So this is really the otolaryngologic piece, what you've painstakingly been learning about and getting confused about over the last half hour or so. This is the diagnostic testing. We're really going to try to provide a comprehensive set of tests to help us determine what the cause of the dizziness or balance is, and then hearing, again, kind of a comprehensive set of testing to discern kind of where the hearing issue is and how we can address it. I'll jump to this kind of next, this is the outreach portion, so kind of giving information about hearing protection. Sorry, this is really small. This is the diagram that I gave Heather when I said, okay, this is what I want to establish. So, so hearing loss or hearing aids, tinnitus or ringing in the ears, kind of what to do about it, as well as kind of support groups, custom earplugs. So some people have ear canals that are been kind of surgically altered, or just want plugs that fit really well, and so we can provide custom earplugs that are molded to people's ears. And then this is probably the biggest part as far as really wanting to centralize, and that is the collaboration. Because as I mentioned, the hearing and balance issues, many people think of ear, nose, and throat, and indeed we are one of the specialties that's frequently involved, but we really need to work with our colleagues in physical therapy, in neurology, in ophthalmology, in cardiology, because oftentimes dizziness can be caused by about 1,000 different things. And so to sort through for each patient, we really need the input from a number of people. So the Hearing and Balance Center hopefully will bring kind of those providers together. We need speech therapy, particularly with the cochlear implants. Psychology and counseling can be helpful for some people that have tinnitus or ringing in the ears. And then for a sudden sensory neural hearing loss, that sudden hearing loss that I mentioned, there's actually some studies showing that hyperbaric oxygen, which we have here in our community, can be helpful. The issue with that is getting insurance coverage, but it can be helpful, so hopefully we'll collaborate with them in the future. The other thing that we want that we've had established at our practice up in Laconia for decades is allergy treatment. And I mentioned we have the American Academy of Otolaryngologic Allergy. And so we treat allergy all the time. I have thousands and thousands of patients. So we absolutely want to bring that to the community. And as ear, nose, and throat doctors, it's kind of an easy access for patients. And if we can provide that at the same office, they usually are very appreciative of that. And that really comes to the end. So thank you very much for your attention and for coming. And I'm happy to entertain any questions.
Thank you, Doc.
My pleasure. My pleasure. Yes?
So my husband snores, so I wear earplugs, foam earplugs. Should I be worried about that?
So anytime you put something in the ear, there's the potential to push that wax back in. So, and I see that, and I don't know if you've had issues with that. Thankfully, no. But I've seen that often with people that need to wear earplugs at work, basically. And sometimes with that scenario that you just described. And so that kind of falls into the, if it gets to the point where it's causing hearing loss or gets plugged, then come in and see us. But in general, probably won't be an issue. Most people, despite what my patients that have a lot of wax production kind of can't believe this, but most people's wax production actually doesn't lead to getting obstructed or having issues with those. And that's why, as ear, nose, and throat, I mean, there are 8 of us right now, 7 of us actually, 8 of us hopefully soon. If we had to get the wax out of everybody's ear in the community, I mean, there would be 100 of us, and we still would probably have our schedules full. So thankfully, wax isn't an issue with most people, but obviously can be an issue. And so much of an issue that, I mean, I would say probably I have a handful of patients that I see almost on a monthly basis because, and it's usually because of anatomy. They have a very small ear canal, and so, it doesn't take much to get that plugged. But again, patients that have hearing aids that are consistently pushing the wax back in, and we just have to get it out before it causes some hearing loss. Sure. Yes?
Do you use a syringe to get the wax out, with some water in it?
Yeah.
Something like that?
So personally, I would say no. I would prefer not. And it really has to do with what I mentioned before, of any water that gets into the ear has the capability of causing an infection or swimmer's ear. Now, thankfully, we can get a little water from the shower or bath or whatever in there, and it usually doesn't cause a problem. But it absolutely can. And particularly if you syringe it, if you have a plug of wax there and there's still an opening, if you syringe and the water gets on the other side of the wax and it can't get out, that can cause some problems. Now, can people get away with that? Absolutely, they can get away with that. I always tell patients, you're playing with fire a little bit when you do that, but you absolutely can get away with that. If you go on the internet, there are probably 20 to 30 other things that are suggested, and I don't recommend any of those. Screws and vacuums and all kinds of stuff. And again, it's all predicated on this assumption that we need to remove the wax and that wax is bad. And so I think if we can just shift, and I wouldn't say it's my life goal, but at least it's my goal with my patients. If I could just shift their perspective of thinking of wax generally as a good thing, and if it does become problematic, then come on in, and we're happy to take care of it and stay on top of it so that it doesn't cause problems. That's generally the safest way to do it. Yes, please.
When I was a kid, I had wound up with a punctured eardrum. Anytime I've gone in the water and put my head under or in a swimming pool, it feels like my whole head's filling up with water.
All the more reason not to do the irrigation.
But I mean, that healed over the years, right?
Okay, good.
But why does just on that one ear?
When you go into the water, it feels like your head's filling up?
Yeah.
And you're certain that it has healed?
I was a little kid when it happened.
Come on and see me. Or, because if you truly feel like the water is kind of filling your head, and it feels very different than the other side, then that perforation may still be there, and you may be getting water into the middle ear space.
Hear it when it's like somebody's got a faucet there. Yeah. So 60 Commercial Street, 4th floor. What's that? Shall I tell you how it happened?
Sure.
I was 4 or 5 years old, and my sister, I'm the youngest of 4, and my second youngest sister, she was playing nurse, and then she says, "I'm going to be the doctor, I got to fix your ear." She stuck a bobby pin in. I remember it like it was yesterday.
Yeah.
Like hell.
Yeah.
And bleeding.
Yeah.
So it's possible it never healed 100%.
It's possible. With a bobby pin, hopefully that was thin enough. And usually traumatic perforations heal pretty well. So my hope is perhaps it's just a sensation that you have with it being in your ear canal against the eardrum, but it's certainly worth checking out.
Okay.
Well, I'm just wondering, because you see these advertisements and you're told if you have earwax that stays in your ear, to use this softening agent. I can use brand name if you'd like me to.
Yeah, and,
You can get generic too.
yeah,
Anyway, so do you advise that or not?
yeah. No. No is the answer. So again, that typically doesn't cause a lot of problems. The most common one is kind of an alcohol-based, and what it does is it changes the consistency of the wax to almost like a frosting-like consistency. And for some people that can be helpful if then they go to irrigate the ear, it can come out a little bit easier. The problem with that is it's much harder to get out as an ear, nose, and throat doctor or as your primary care. Some of the primary care doctors will actually use a curette to get wax out. It's much harder to get out because it's like, you know, again, you stick in a curette through something that's frosting and it just, you know, pulls right through it. And again, I'll come back to, and sorry I keep harping on this, it's those products are based on the falsehood that we need to get rid of it. So as long as it's in your ear and not causing problems, it's actually helping you. It's preventing infection, it's catching debris, and it will move out of your ear. That diagram that I showed you of the skin migrating, and then when it gets here, then just wipe it away. But if, you know, in general, I don't suggest those. Probably if you're going to do one thing, and this is a common thing that I suggest for some patients in different scenarios, if you're going to do anything, it's much better to use like oil, like mineral oil, medical grade mineral oil. Mineral oil doesn't have a smell, doesn't have a taste, the body doesn't react to it. It's packaged as a stool softener because you can swallow it. Has nothing to do with stool, other than the fact that you can swallow it, because sometimes I, you know, say that and patients go, "You want me to put it in my ear?" But it's very handy with the ear. And it softens the wax a little bit, and it also does what oil does, which is get in between things, and it gets in between the skin and the wax. So it prevents the skin from getting so stuck down to the wax from getting so stuck down to the skin. I don't suggest doing that, but that's, you know, if somebody recommends the wax softening, that's a much better option to do than the ones that are available over the counter.
Thank you.
Yeah. Sir.
Yeah, hi. I know a lot of you in the room. My name is Warren Emily. I was an otolaryngologist, and I can say it. It rolls right off because I've done it for over 40 years. In Concord for over 30 years. And I'm delighted that you're here, Dr. Marietta, because it is a really misunderstood specialty, excuse me. When I first came in '75, just a little historic anecdote, I had all this training that you've described. It's 5 years of really surgical training, and I was really hot off the press and ready to go. And some of the doctors I met at Concord Hospital said, "Oh, you're the new nose and throater." Nose and throater, what's that? Or another one was, "Oh, you're the new nose picker." I thought, boy, I've got a lot of work to do here to educate people about what I can really do. And it took an entire lifetime to really explain to the community and to the medical community, other doctors, what does an otolaryngologist do? And so that's what you and I, and all of us with that training need to do, is let people know what is available, because you folks out there, gee, should I call it ear, nose, and throat guy, or what should I do here? I understand your confusion about that. But ideally, the medicine still works with good primary care who knows who does this type of work best and refers you appropriately. It's a very, very interesting specialty. I have a couple of medical questions just to toss out to you, Chandler, if you don't mind.
Please.
See if you can, what you do with these. We hear in the world of surgery, everything is going minimally invasive. You don't get a cut up here for your gallbladder, you go through the navel, endoscopes and all that kind of stuff. Can you comment on minimally invasive surgery in the modern era with respect to otolaryngology? Just let me add a piece to that. Robotic surgery, you know, the robot. Is there any role for robotic surgery in ear, nose, and throat? And then the last thing I'll toss out to you.
Mhm.
We all know about COVID. That virus gets into our bodies through the nose, ear, nose, and throat. I'm wondering if in your specialty, in our specialty, if you have any advice for those of us that are going out without our masks now and we're breathing in some kind of air. Is there anything we can do of a preventive nature to limit the amount of viral exposure we can get? Is there something about the nose that we can really jump on right away and protect ourselves if we have unfortunately inhaled some of that virus? Okay, you can answer any of those questions you want.
Okay. Those are great questions. So the last one first. So with regard to COVID, so our specialty, as almost all the specialties, these over the last couple of years, has really been focused on COVID, and I would probably say in general, nothing that has been definitively proven, unfortunately. So, and again, that's me being very diplomatic to my colleagues. So, if we have something that's really definitive, hopefully you guys would already know about it. So, so there have been some studies showing, well, what about if we, take a little bit of dilute betadine and put it into a sinus irrigant and kind of irrigate? And there have been some suggestions that might be helpful, but certainly that has the potential to cause some issues depending on how much you dilute it or not dilute it, getting the appropriate iodine, getting how often you do it, and so in general, that's why it hasn't been recommended, because we really don't have the studies yet to show, is this really preventative? So unfortunately, I would say no. We don't have that, other than, of course, the vaccines that we have. With regard to the second question, so I showed the picture of kind of minimally invasive ear surgery. So, and a lot of it is based on telescopes, or endoscopes, and that really has completely changed our practice, and in our practice as well as many others. So there used to be a time when when you went in to do surgery in the sinuses, where you would make an incision underneath the lip and actually kind of make a hole through the bone and go into the cheek sinus kind of via that way. It's called a Lothar procedure. I did one of those in my very early years, and ever since then we do them all through the endoscope through the nose. So the endoscopic ear surgery has been over the last 5-ish years. It's really kind of coming up. And what it allows us to do is, instead of making an incision behind the ear in many situations and flipping the ear forward and then kind of getting access in that way to the ear, because the ear canals are pretty narrow, I can do many things just through the ear with the telescope. And that saves kind of obviously not only the incision, which almost always heals well and doesn't cause any problems, but mainly the recovery. So patients really just have a little bit of discomfort and almost never need any pain medicine because everything is kind of through the ear. With regard to the throat, the robotic surgery with head and neck cancer resection absolutely is coming into use. A little outside of kind of my experience, but just in my exposure at our meetings, yep, absolutely. Trying to find ways to institute that really help the patient and give us more exposure, because all of our areas are all these holes in the body, and they're small little holes. And so doing procedures, doing surgeries on these areas is very challenging. So anything that gives us increased exposure actually increase. It's not just about evolving. It's not just about, we're doing the next best fancy thing. It actually many situations improves care, not only by recovery, but also just exposure. We can see so much more. And as an otologist, as an ear surgeon, in using the endoscopes, again, it's kind of come up well after my training. So I've kind of taken it on in the midst of practice rather than just learning about it during all my other training. Just what I can see in the ear with the endoscope is totally different than what I can see through a microscope looking through the ear canal. It's pretty good, and it's pretty good for most things, but you have angled endoscopes that allow me to go in and look over 70 degrees. It just really expands kind of the exposure. So yeah, it's played a huge part in our specialty. Thyroid surgery, they're going in all over the place, getting access to try to minimize the scars. So yeah, it's a huge part of our specialty.
Any other questions for Dr. Marietta? Thank you so very much for
You're
joining
welcome.
What's Up, Doc,
My pleasure.
today.
My pleasure.
I don't know about everyone else, but I certainly learned a lot. I'll go to confession and tell you I'll go home and throw my Q-tips away. We look forward to hearing more about the Hearing and Balance Center. And we just want to thank you so very much. Thank you to all of you who joined us
thank you for coming.
today. And for those of you who tuned in on our virtual options, we're very happy. The Concord Hospital Trust is happy to bring you the latest information about healthcare issues, treatments, and providers. And certainly if you have an ear, nose, or throat issue, call Dr. Marietta.
You bet.
Next month, up for What's Up Doc will be Dr. Michael Newton, who will be here from the Concord Hospital Cardiovascular Institute, and he's going to be talking about advanced cardiac imaging, catching the beat of the heart. So it should be really terrific. Go and enjoy, have a great weekend, stay safe, stay happy.
Oh.